致歉，我啱有個電話個記者捉住唔放，唔好意思，唔好。
Sorry, I think we can start now. Agenda item number 1. Information papers issued since the last meeting. We haven't got such papers. Item 2. Items for discussion at the next meeting. Members can refer to the 2 papers under this item. Please invite the administration in.
當局呢就係講。
The administration has proposed 2 items, namely extension of operating theatre block of Tuen Mun Hospital and progress of tobacco control measures. Right, members? Any suggestions? Yes, we welcome the administration's team. Ms. Helena Wong. In a hospital, someone who was not a doctor pretended to be a doctor and carried out ward duties in a ward. So I'm worried that in the future, if I need to undergo an operation, someone who's not a doctor may do some harm to me. According to the secretary, there will be a comprehensive review to be conducted by the hospital authority on security measures in HA hospitals. So this is an isolated incident, but if members want to have a discussion on the matter, then we can invite the HA to come to brief us on security measures in public hospitals in Hong Kong. Let's not discuss an isolated incident. If members are interested in discussing the security measures in the public hospitals in Hong Kong, then we can ask the administration to prepare a paper for us, and then we can have a discussion next time. Now, on previous occasions, there were children who were taken away from children's wards in public hospitals. Right, so let's discuss a total of 3 items next time. Any other suggestions? No? Then we can move on. Yes, Mr. K.K. Kwok, Chairman. Concerning mental health services, the Undersecretary has promised to bring the matter back to the panel for discussion before the end of the year, and that relates to services for children. I want to know when we're going to have a discussion on this matter. I understand that there is another committee or subcommittee looking at the report on review of mental health services. So perhaps, Undersecretary, you can tell us the progress. Last time, Chairman, we were told, in fact, that was last year, we were told that the matter would be discussed again by the panel in April. But then that committee hasn't really completed its work, and so I don't know whether they've got any progress to report to us. Undersecretary. Yes, Chairman. In fact, that committee is still having meetings. So I will try to find out more about the progress that has been achieved, and we will come back to this panel sometime this year. Mr. K.K. Kwok is correct. Now, in fact, you previously said that the matter would be discussed by the panel again in the first quarter of 2015. Maybe they won't be able to come back to us till the 3rd or 4th quarter of the year. I think if they are ready, we can hold a special meeting to discuss the matter. In fact, we've been waiting for the report for a long time. Now, in fact, the committee has not completed this work yet. Yes, I think we should ask them why they have got such delays. All right, so 3 items next time. Security measures at public hospitals in Hong Kong, and then extension of operating theatre block of Tim Mun Hospital, and then finally progress of tobacco control measures. Then we can now move on to item 3, revision of fees and charges for services not directly affecting people's livelihood under the purview of the Department of Health. Under Secretary, do you have anything to say in relation to this paper? Yes, thank you, Chairman. So we're proposing to adjust 118 statutory fees relating to the registration of healthcare professionals. We'd like to hear your views on the matter. In fact, we adopt the users pay principle, and we think that the fees and charges of government services should be, in general, set at levels sufficient to recover the full cost of providing the services. In his budget speech 2013-14, the FS stressed that the government needs to ensure a stable income by preserving tax revenue and adhering to the users pay principle in order to uphold fiscal sustainability and prudent management of public finances. And to prevent cost recovery items from being turned into heavily subsidized items, the government will review the fees and charges. We'll first deal with fees that have not been revised for years and do not directly affect people's livelihood, as well as items which have low cost recovery rates. The government has undertaken not to implement substantial revisions at one go to avoid affecting people's livelihood. Before members, 118 statutory fee items relating to the registration of healthcare professionals. The fees were last revised between the year 2000 and the year 2006, and the cost recovery levels at the moment range from 11% to 116%.
And for among those 117 fees, the increase ranged from 7 to 20%. And for most items, the increase is less than $100. And under Annex A, Item 108, the fees of certain items will be reduced by 14% if the amendments are accepted. The cost recovery rates can be improved to the range of 13 to 100%. All the fees would have relatively little impact on the daily life of the general public or business activities. We will continue to streamline our procedures in order to control the costs of these services provided to the public. And we will consult the relevant institutions, and under Annex B, the bodies we will consult have been listed, and members of these bodies generally have no objection to the proposed fee revision. Going forward, we will amend the relevant subsidiary legislation, and the administration plans to table the relevant legislative amendments before the Legislative Council within the 2014-15 legislative session. So hopefully members can share their views. We have Dr. K.K. Kwok, Dr. Lena Wong, Mr. Poon Siu Ping, Dr. K.K. Kwok, 3 minutes each, please. Chairman. On the increases, the administration mentioned that they would not, these adjustments would not affect the general livelihoods of the public. You said that what you have done would not affect the livelihoods of the public, which implies that what you will do next will affect the livelihoods. Can you let us know what are the items you will adjust in the near future? As we can see, the cost recovery levels would be increased to to recover most of the cost, does it mean that you are going to adjust the fees again very soon? And for certain jobs such as nurses, therapists, and midwives, it won't be a very big problem. But for the first registration for nurses and doctors, the registration fees are rather high. For example, for dentists, the recommended fee is $2,170, and with the fees being so high, a lot of professional grades would ask the question whether the government has done enough to control the registration fees. And in turn, they might have to defer the increases to the patients. So the question is, has the government conducted any reviews to contain the costs? And is there any room for streamlining the staff? And for those who have to pay their first registration fees, the burdens are rather high. Would you consider lowering the increases in order to ease their burdens? For more experienced professionals, the issue won't be that serious. Is this something the government will consider? Thank you very much, Dr. Kwok. Basically, we adopt a user pays principle, and basically we are focusing on items with lower cost recovery levels and items that would not affect the livelihoods of the general public. So we have no timeline as of when we will adjust the fees again. And for the second question, under the annex, are we going to adjust the fees again? So your goal is full cost recovery, right? Under paragraph 4, you can see that we would basically look at the current cost recovery levels. If it's less than 40%, we would increase it by about 20%. For 40 to 70%, we would increase it by about 15%. And for existing rates of over 70%, we will make an increase of about 10% or less. For items with an existing cost recovery rate of over 100%, we would actually adjust the fee downwards. So that's our principle. And for your third question, we would not consider whether it's the first or second registrations when we adjust the registration fees. So our focus is still on cost recovery. And all along, the Department of Health has done a lot of work to contain our costs. For instance, streamlining our procedures, the increased use of computer systems, enhancing communications in order to save time, etc. And all these would help contain costs. So perhaps the Department of Health can give more on their work. As the Undersecretary just said, we would continue to streamline our procedures in order to enhance efficiency. So we have managed to limit the increases in costs, and we would make sure that all our staff are utilized fully. And we wouldn't have any redundant positions. And for certain items, the costs have actually dropped when compared with the past. Chairman, can we request them to provide us with figures? You might have some kind of formula when you calculate the cost recovery levels. Can you provide such figures after the meeting? Dr. Lina Wang. Chairman, under paragraph 9 of the paper, to avoid increasing the fees to a high level, which would discourage eligible candidates from sitting the exam, we would consider retaining the existing calculation methodology. But under the annex, a lot of items are related to the license exam fees, and a lot of these fees have been adjusted. But according to the paper, they said that they would avoid increasing these fees. But the fact is, these fees have been increased according to the annex. Thank you very much for the question. And we have actually considered the examination costs, but we have not accounted for these costs fully. Our practice is that for Part 3, which is clinical examination, all along this exam has been hosted by CUHK and HKU. And as we have increased the number of sittings to twice a year, we have not included the costs incurred by these universities in the costs. Since these costs have not been included in our current calculations, since we have yet to achieve full cost recovery, we would like to recover some of those costs, and later on we will conduct another costing review. So in other words, you will increase the licensing exam fees, right? We have increased some of these costs for those which are not covered at the moment. We will think about what to do with them at a later stage. And for items which have not been included, have you included them in your formula? We have not included those costs in the current formula. Under Annex B, you said you have consulted certain bodies, and you said that most of them have no objection. So my question is, did any of those bodies object to the fee revision? And what have you done with those objections? We have consulted 12 bodies, and none of them objected to the fee revision. So that means all of them agree to the revision, and they have no, they have nothing to say about the revision, right? They have no objection to the revision and current mechanism. Mr. Poon Siu Ping. We are talking about 118 statutory fee items. The last revision was conducted between the year 2000 and 2006. According to the Undersecretary, for items with a cost recovery rate of less than 40%, you would adjust it by about 20%. Apart from these 118 items, well, it has been almost 10 years since the last revision. Is that was that what you did in the past? Was it your practice to adjust items with less than 40% recovery to and adopt an increase of about 20%? You are going to adjust the registration fees of different medical professionals, and in some cases the costs might be transferred to the public. So how can the government determine that the livelihoods of the general public would not be affected? In response to your last question, we basically adopt the user pays principle, and we have consulted the relevant stakeholders, and they have no objections. If you compare our current fees to other countries, they are not high at all. So as such, we do not believe that the costs would be deferred to the consumers, and the increases are very mild. the increases range from 7 to 20%. If you look at all the items, for more than 60% of the items, the increase is less than $100. And these levels should be affordable to most medical professionals. And in response to your first question on the figures, Mr. Poon, do you want to know about the extent of increases for each item? I want to know two figures. First, the total figure for all 118 items. How many items do you have in total? And second is the fee adjustment period. The last adjustment was done in 2006. Why are you revising it this year? Did you plan to revise it regularly, or would you only look at the current situation? We haven't really set a line on when we would conduct adjustments. Between the year 2000 and 2006, we have made some adjustments, but we have not adjusted the fees again after 2006. And according to the Financial Secretary's announcement in 2013 to 14, he stressed that we would adhere to the user pays principle. As I said, for items with cost recovery rates of less than 40%, we would increase them by about 20%. So that's our thinking. Apart from 56 items which have undergone an adjustment in 2006, other items, the fees for all other items have remained the same for a long, long time, for more than 10 years. So perhaps Mr. Wong from the Department of Health can give more. Thank you, Chairman. On services not directly affecting people's livelihood, we have 238 items, and we are going to revise the fees of 118 items. And for items affecting people's livelihood, we have about 100 items.
It's surprising that no more members would like to ask questions. A total of 3 members have asked questions on this paper. So let's move on to item 4 on the agenda. Cross-cluster referral arrangement for public specialist outpatient services of the hospital authority. All right, so let's invite the next team of officials in.
或者我哋等緊嘅時間咧。
While we are waiting for the other officials to come in, can I invite the Undersecretary to take us through this paper? Yes, thank you. This paper briefs members on the cross-cluster referral arrangements for public specialist outpatient services of the hospital authority. With an aging population and increasing prevalence of chronic diseases, the new case bookings at SOPCs have increased by around 5% over the past 3 years. Now, at the moment, we're suffering from a shortage of staff, especially doctors. Now, we only had 250 medical graduates in 2011, 280 in 2010, and 310 in 2007. And so it's difficult for HA to cope with the escalating demand. At the moment, the HA has or implements measures like hiring part-time doctors to increase the capacity of its services. But then the increase of new case bookings has outpaced the new case clearance rate, and as a result, waiting time in the past years has been lengthened. But I must point out that this applies only to those patients with less severe and non-urgent conditions. Nevertheless, I want to say that the HA has in place a triage system to make sure that those with urgent conditions and require early intervention can get treatment in a timely manner. Now, in fact, for the median waiting time for urgent and semi-urgent cases, the median waiting time has been maintained at 2 weeks and 8 weeks respectively. In fact, HA has implemented measures to manage waiting time in SOPCs. For example, we are enhancing primary healthcare services. And we are also enhancing manpower at SOPCs. Next, we have been exploring public-private partnership possibilities on clinical services. We've also improved management tools for waiting time, and we've also enhanced the transparency in SOPC waiting time. And so in 2015-2016, the number of attendances at HA SOPCs can increase by around 20,000. But many of these cross-cluster referral measures take time to realize the benefits, and so we have tried to enhance cross-cluster referral arrangement. So for patients with suitable clinical conditions, they will be invited to receive treatment at SOPCs in other clusters with shorter waiting time. Now, at the moment, this arrangement is implemented in selected clusters and also in selected specialties. And last year there were about 4,500 such referrals. Waiting time for patients was shortened, and the discrepancy in waiting time for different clusters was also narrowed. So members can refer to the table in para 14 for the details. Now, although this cross-cluster referral system is effective, it has its limitations. It can be implemented only in selected specialties and clusters. And also, in January this year, HA has uploaded the SOPC waiting time information for all 8 major specialties on HA's website. And so patients will know more about the waiting time for different specialties in different clusters, and they can, as a result, make informed decisions when considering whether to pursue cross-cluster treatment. In order to shorten the long waiting time at SOPCs, this is in fact a top priority to the HA. The HA will continue to enhance the cross-cluster referral arrangement. It will also review its services in order to provide patients with timely access to the services they need. Now, in fact, Dr. Au has not arrived yet. This is because this item started earlier than scheduled. Dr. Au will tell members more about the cross-cluster referral arrangement. He will tell members more about the present waiting time and also the challenges that the HA faces in different clusters and in different specialties. As I've said, we have uploaded the SOPC waiting time information for 8 specialties and 7 clusters, and Dr. Au will tell members more about such developments. Right? So while we are waiting for Dr. Au, we can invite questions from members, Dr. Kiki Kwok, Dr. Leung, and Mr. Pushu Peng. We have ample time for discussion. But then Dr. Au is not here. You can ask the questions first. But when will he arrive? Because we started this item earlier than expected. So, Chairman, should we wait for him to come first? Because I do have questions on the detailed arrangements. Now we have a lot of time left, and members can ask questions, and if there are questions that the Undersecretary cannot answer, then they can be answered by Dr. Au when he arrives. Dr. K.K. Kwok. Yes, Chairman. Within the hospital authority, there is a shortage of resources, and its resources are not evenly distributed. We are only using about 2% of our GDP on HA services. So the public are spending more than the government on public sector hospital services. So if the government keeps saying that it has a very heavy financial burden providing funding to the HA, then I think such a remark is misleading. In fact, advanced economies and countries spend 6 to 7% of their GDP on public healthcare services, but we in Hong Kong only about 2%. Now, you know, different clusters, they compete for resources, and they're not willing to share their resources with other clusters. Dr. Koh is not here today. I think this is really the cause of the problem. Now, concerning this present arrangement, we cannot oppose the arrangement, but I don't think the arrangement can really solve the problem. At the moment, the cross-cluster referral arrangement is implemented only in 3 specialties: ENT, eye, and gynecology. So is it that the arrangement will be extended to other specialties, including psychiatry? Undersecretary. Yes, I'll answer the last question first, Chairman. We have 8 specialties and 7 clusters, and the waiting time information is uploaded onto the HA's website. If a patient sees that the waiting time in a particular cluster is rather long, and he prefers to go to another cluster for treatment, then he can inform the cluster that he belongs to, and the cluster staff will make the necessary arrangements for him. That said, our staff do make recommendations to patients who make such requests or applications. Some patients need prolonged follow-up services or community support services within the same cluster, and so they may not be suitable candidates for the arrangement. Now, concerning the 3 specialties, eye, ENT, and gynecology, the cross-cluster referral arrangement is being implemented. What about the remaining 2 questions? Clusters holding on to their resources and unwilling to share their resources with other clusters. Now, in fact, we are having reviews in the HA. We're looking at the waiting time in different clusters and also the allocation of resources among different clusters. The report should be available in June this year, and we will report back to members at that time. The report will contain some recommendations for the HA and how the HA will take the recommendations forward. Dr. Leung, I think I will need some replies from Dr. Au. I think for the technical details, you can ask Dr. Au, but I think you can ask the Undersecretary policy matters. All right, perhaps you can record my question, Chairman. I want an explanation of the cross-cluster referral arrangement. According to the Undersecretary, the patient has to go to his cluster and ask the staff to make the arrangements for him. That's rather inconvenient and cumbersome for the patient. Now, because the cluster may not know how much community or follow-up support the patient needs. Now, I thought that the patient could look at the waiting time in different clusters and say if he feels that the waiting time in Kowloon East is too long, then he goes straight to Queen Mary. And then the quota in Kowloon East will be reduced accordingly. That was my understanding. So that's what is called patient's choice. Right, Dr. Au is here. Perhaps if I have time, I can repeat my question to Dr. Au. I've got 2 more questions, Chairman. Now, I am still working in HASOPCs. My impression is that over half of the cases, in fact, do not have to be handled by SOPCs. It is just that patients have no family doctors or general outpatient clinics to turn to. So can I ask the HA how many percent of the patients attending SOPCs in fact do not need specialist outpatient service? That's the first question. And then here's my second question. If you allow patients to choose the clusters that they prefer, this arrangement, of course, relates to patient's choice. But at the same time, policy backup is required. If you allow patients to go to whichever cluster they like, then what if all patients go to Queen Mary and Prince of Wales, because these are the 2 teaching hospitals in Hong Kong? Now, in the private sector, if all patients go to a particular clinic or a particular hospital, then now of course the clinic or the hospital will try to take in all these patients, but then this is the public sector.
But in the public sector, if you allow patients to go wherever they want, in terms of policy and resources, are you going to provide any support? And my third question is, well, that's a question I wanted to ask Dr. Au on the cross-cluster referral arrangement. At the moment, can patients choose whatever cluster they wish, or will the referrals have to be arranged by the patient's original or existing cluster? Since Dr. Au is here, well, perhaps you can decide who is to answer the questions. So perhaps we would allow Dr. Au to catch his breath first. In terms of the cross-cluster referral arrangements, we would like to know the HA's plan. So perhaps you can address the 2 questions from Mr. Leung first. Dr. Au has something to say, right? Mr. Leung asked 2 questions about policy, so perhaps you can address those questions first. I have 3 questions. One of the questions would be tackled by Dr. Au. Well, we do have a lot of time, but I hope everyone can still be concise. And the first question is, what percentage of patients in SOBCs can be dealt with elsewhere? Thank you very much. Yes, we do have such cases, as far as I know. And one of the HA's initiatives in managing waiting times is to enhance primary health care. For some cases, the patients do not need to go to SOPCs. They can just visit general outpatient clinics or family doctors. And I understand that the HA has done something to deal with such cases. And some of these cases can be referred to general clinics, and as such, the burden on SOPCs can be eased. My question was, what percentage of the patients do not have to go to SOPCs? I want this figure. Of course, I know there are such cases. What I want to know is the actual figure, so that we know how you can improve. If it's just 10%, well, perhaps we should save our time. But if the figure is 50%, then it's very different. So do you have such figure? What percentage of the SOPC patients do not need to be managed at specialist clinics? Well, the simple answer is no. If you're talking about the overall percentage, according to non-official figures, for some specialist cases, for example, for some orthopedic cases, in some cases, let's say 10 or 20% of patients with back problems can be dealt with by family doctors. So these are some information we obtained through unofficial channels, but we have not done any formal surveys or studies. This is a two-way process. The patients must agree with the referral arrangements as well. So if we are to go into this topic, we have to consider the consistency among the doctors in their diagnosis. In some cases, the patients can be taken care of by primary healthcare services. Dr. Au, Mr. Leung said in terms of SOPCs, some patients can be dealt with elsewhere, and that's why he raised such question. And you said that you don't have this figure on hand. So does the HA have any figures to share for cases in which SOPC patients are being referred to general clinics? We do have some combined figures. If you have such figures, that means you can avoid the scenarios mentioned by Mr. Leung. If some patients don't have to be dealt with in SOPCs, they can be transferred to GOPCs. For certain closed cases in specialist clinics, patients can be referred to GOPCs. But you cannot say that these cases do not require specialist care. What Mr. Leung means is that they don't have to be, they don't have to go to SOPCs anymore. That's not the key, but this question is very important. The goal of having such cross-cluster referral arrangements is to shorten waiting times. If some patients can be dealt with in GOPCs, the waiting times can be shorter. So do you have such emplacement in place? So Mr. Leung is a patient at SOPCs himself. If you are to facilitate such arrangements, do you have the necessary resources in place? At the moment, DHA's practice is that all hospitals in the clusters are aware of this arrangement. But of course, they do have their stipulated capacities. They do have upper limits on the number of patients they can admit. And some clusters might have longer waiting times than others. So perhaps DHA can provide more details. So I guess everyone is quite puzzled. So perhaps we can have Dr. Au clarify the matters with us first before we take in more questions. Dr. KK Kwok, I guess you have to wait until Dr. Au finishes his part before you continue. And Mr. Leung, if you have anything to follow up, you can ask your questions later. Dr. Au, please. And for 3 specialties, we have arrangements in place, as you all know, and we will continue the arrangements. And under each specialty, we would adopt the same practice. Which is to announce the waiting times for non-urgent cases. And if patients get a very long waiting time at a specific cluster, then the doctors might refer them to other clusters with shorter waiting times. The arrangement is different from that for fixed specialist services. The practice has been in place for about 2 months. And some of our staff are a little worried about the additional burden created by the movement of patients. But so far, in the first 2 months, because of a lack of publicity, we have not seen such issues. When we look at the figures, a lot of clusters have seen extra referrals from other patients. And before we came here today, we invited Dr. T.L. Lee to look at the flow of patients in 7 clusters. In the first 2 months, the number of patients from local clusters to non-local clusters accounted to only 1.5 or 2%. It's 2% for Hong Kong East. So the current percentage is about 1 or 2%. Well, assuming this ratio remains more or less unchanged throughout the year, and this is a big assumption, for each cluster, we would have about 100,000 new cases per year among all SOPCs. If it's at 1%, the figure will be 1,500. At 2%, 2,000 cases. And a lot of clusters have observed that the choices of these patients do not only depend on waiting times. We are talking about a lot of non-emergency cases, and in a lot of these cases, from what we can see, most patients would opt for a few options. They would first consider the locations of the clusters, and a lot of the patients won't want to leave their own region, and this is especially obvious in New Territories West. And for Queen Mary Hospital in Hong Kong West, the waiting times are rather short. But the number of referred patients have not increased. On the other hand, a lot of their patients have been referred to other clusters, which shows that a lot of patients prefer to go somewhere near where they live or work. So this is a very preliminary phenomenon we observed. So if you have nothing else to add, we can come back to Mr. Leung's question. Well, I have spent a lot of time, and I'd just like to be quick. I just want to confirm one thing. Can the patients choose to go to other clusters? For instance, if the waiting time in Hong Kong East is shorter, they can choose to go there, right? They need a referral letter before they can be referred to, say, Hong Kong West. If the waiting time in Hong Kong West is 3 years, then they can choose to go to Hong Kong East, right? Or can they just go online and check the waiting times of different clusters? Well, either scenario is possible. They don't have to actually visit those hospitals. They can simply check the waiting times online, and they can read the tables online. Basically, our frontline staff would encourage patients to visit hospitals in their own region, but they would have to make their own bookings.
For allocation of resources, I believe you haven't got the arrangements yet. I hope that you can take this into account in the allocation of resources, because some colleagues in some clusters may complain to me. They may think, oh, we are doing a good job, we are being very efficient, and then you are giving me more patients. So in other words, if you do not give such clusters more resources, then the staff will think that they are being punished, or they will be punished for being efficient and competent. Yes, we will be monitoring the situation. Thank you. Mr. K.K. Kwok, because you said that you would like to ask Dr. Au some questions. Yes, Chairman. In fact, we're not against this arrangement. I think Dr. Au knows that, in fact, we're just going back to the arrangement in the past. In the past, patients could have a choice concerning which hospital they would like to go to. Dr. Au said that some patients wanted to remain in their own clusters. Dr. Au said that residents in Tuen Mun didn't want to go to other hospitals because they had a lot of trust in Tuen Mun Hospital. That may not be the case. You know, these residents have to go to follow-up consultations on a continuous basis, and these are though residents who do not have a lot of means, and can they take public transport from Tuen Mun to Queen Mary every time? You know how expensive traveling expenses are. And then say if they want an MRI, then they may have to wait for 2.5 years in Tuen Mun. And then if they need physiotherapy, they will have to wait separately. I want to say that some patients simply will not go to other clusters, although they may attend the first consultation in another cluster. Now, this is because if they need physiotherapy, then they can't go to physiotherapy sessions in another cluster every time. And what if they have to undergo an operation? They can't undergo an operation in another cluster. It would be too far away. So you have to take into account the difficulties of the residents. You know, some residents in some clusters have to wait for over 100 weeks for orthopedics consultation, then mental or health or psychiatric patients, they have to wait for over a year. You may think that a pain in the back is not fatal, but then a patient suffering from a severe pain in the back may not be able to work. So you are just trying to sweep everything under another carpet. And as a result, this carpet may appear very clean. Island or Hong Kong Island East, only about 7,000 new cases. But then Kowloon East, 13,000. And then Kowloon West, 18,000. NT East, 17,000. NT West, 10,300. So what's the problem? Is it shortage of staff, shortage of manpower? Or is it that some specialties simply can't take on further cases? Or is it that the cases are really too complicated? Asking patients to go to other clusters cannot solve the problem in the long run. At some hospitals, you need to increase the manpower supply in order to handle the ever-increasing number of patients. I think the hospital authority should look at the manpower demand in different specialties and different clusters. And you have to try to rectify the problem in the next 2 to 3 years. You can't say, oh, historically, this hospital has all along had more manpower, and so let's ask the patients to go to other clusters for treatment. This is not the way we in Hong Kong handle problems. So I want to know whether Dr. Au or the Undersecretary have got the figures. Yes, Chairman. I'll say something about the principle and then Dr. Au can supplement, Chairman. I want to say that the cross-cluster referral arrangement is just one of the measures to manage waiting time at SOPCs. In fact, there are, of course, limitations and constraints, and HA has got other measures in place. For example, enhancing primary health care and exploring more possibilities for PPP. The hospital authority will look at different specialties and different clusters. It is not that the HA only knows how to ask patients to go to other clusters for treatment. Dr. Au. Yes, Chairman. we are not only working towards short-term targets or indicators. As members are aware, there are specialties with very long queues, for example, orthopedics. So we look at outpatient services, patient discharge, and also a number of operations, and we are now analyzing the manpower situation in different specialties. In fact, we have had a recent review from orthopedics, and last week we sat down with COSs of orthopedics departments in different hospitals, and in fact the chairman was also present at the meeting. So we're looking at the waiting time in the special outpatient clinics, as well as the manpower situation with regard to operations and wards. In a cluster, we have to look at the situation in the wards and the situation in the special outpatient clinics, and then we work out the manpower arrangements. And even if we have extra manpower, we may not be able to achieve very significant improvements in a particular cluster. And then in the West cluster, there are many hospitals, so we have to try to even out the workload among the different hospitals in the cluster. And in some clusters, there are different subspecialties under one specialty. And so, say for example, orthopedics, the back pain subspecialty may have a very long waiting time. But we look at the 90th percentile waiting time. For orthopedics in general, the waiting time was over 100 weeks in about 3 clusters, and now we've got 4 or even 5. So you can see that in fact there is a rapidly increasing demand for services in a specialty. The problem is that we simply can't catch up with the aging population. So last week, we at the meeting agreed that the aging population would create an ever-increasing demand on orthopedic services. And so when there is an improvement to the supply situation, we'll have to really give priority to orthopedics. And then we need to work out other improvement measures in the clusters. I have mentioned orthopedics in particular because I think it's an example to show that we need to look at SOPC and other services within the specialty as a whole. And an aging population is going to bring quite a lot of pressure to bear on the HA in the coming few years. So you spend 10 minutes to tell us about orthopedics, but then say in Tuen Mun the waiting time may be 3 years, and then QM only 3 months, and so the patient, according to Dr. K.K. Kwok, the patient may not be able to travel so far and the travel expenses are high. And then, as Dr. K. has pointed out, then he may need an X-ray examination, he may need an MRI, he may need physiotherapy services, and how can he go to Hong Kong West every time for such services? So after he has seen the doctor or has got the first consultation session in the Hong Kong West cluster, can he have other follow-up services in Tuen Mun and not in Hong Kong West? Now, Chairman, we do not really require patients to suit our resource allocation. For imaging and treatment, the waiting time is monitored separately. For example, we look at MRI and CT scanning waiting time in different clusters. We carry out planning as to where MRI and CT scanning services should be stepped up. But of course, we'll also need to increase the manpower resources. Chairman, I don't think he has really answered my question. But then, Mr. Kikkwok, you've already used quite a lot of time on your question, so perhaps you can queue up again in the second round. Mr. Poon. Yes, Chairman. I think my concerns have already been expressed by other members. The waiting time is long, and patients may want to go to clusters with a shorter waiting time. So it seems that this arrangement is open to new cases as well as old cases. And I want to ask about psychiatry. There may be cross-cluster referral for psychiatry in the future. Then what about the HAE's timetable to expand the arrangement to other specialties?
So perhaps I will invite Mr. Ao to walk us through this question. For psychiatry, it has always been treated separately. For psychiatry, the specialist doctors are more concerned with the management of patients, and preferably patients would be treated in their own areas or clusters. So at the moment, we do not apply cross-cluster referral arrangements for such patients. And since the 7 clusters are centrally coordinated, the doctors have come together to discuss what we should do going forward. And at a recent meeting, they have decided to apply the arrangement for patients with mild psychiatric conditions. And the issue is whether we would allow the patients to be referred to any of the 7 clusters, or should they be referred to one specific cluster. This way, it would make it easier for us to follow up on the patient's cases, and it's also a safer option. than allowing them to make a free choice. And later on, we can conduct follow-up and assessments for these patients. After the meeting today, we will continue to work with the Coordination Committee of Psychiatry, and hopefully by the second half of this year we can roll out a pilot scheme for psychiatric patients. And of course, when we deal with these patients, we have to be very careful. Mr. Albert Ho. Thank you, Chairman. At the moment, the cross-cluster referral arrangement has been applied to 3 specialties. And actually, the patients can transfer themselves to other clusters. And even under this referral arrangement for Kowloon East, the waiting time for certain specialties have reached 98 weeks. So these are routine cases. So I think the waiting times are way too long, even for the waiting times of 33 weeks, 66 weeks, etc. How long do the patients have to wait before they can get a follow-up appointment? So in other words, they can only pay 2 visits in 4 years. So my second question is the length of time patients have to wait for a follow-up appointment. You talked about psychiatry, but for specialties like surgery, pediatrics, etc., do you have a timeline on when the referral mechanism can be applied? Well, to some extent, you have solved certain issues, but as Dr. K.K. Kwok, there's still the issue of inadequate resources and uneven distribution. But the shortage of resources remains. I hope you can come up with some solutions to encourage retired doctors to continue providing services. I don't know whether there are lots of these retired doctors out there. You talked about new doctors, and the Democratic Party really hopes the hospital authority can relax the recruitment of new doctors. And you mentioned the number of medical graduates. The number of graduates have gone down since 2007. So after 2011, has the number of students increased again? Well, the latest figure is, the figure at 2012 is 420 graduates. Can you address my question, please? Thank you very much. First of all, for follow-up appointments, we do not collect figures on waiting times because the waiting times really depend on the respective conditions. It's the follow-up appointments would be clinical decisions made by doctors, and it varies by patient. And apart from those 3 specialties you mentioned, starting from January this year, DHA has extended the arrangement to 8 specialties among the 7 clusters. And patients would be able to check the waiting times for these 8 specialties online. If a patient wishes to be referred to another cluster with a shorter waiting time, it would be possible. And I'm talking about new cases. And in terms of manpower, DHA has done a lot of work in terms of eliciting retired doctors. Perhaps Mr. Au can tell us more about the new initiatives. And this is indeed one of the solutions in tackling the manpower shortage. We are providing a special honorarium, and we are recruiting some retired doctors. And for your final question on the Hong Kong Medical Council, we are hoping to encourage more graduates in joining our forces. For retired doctors, as I conducted the manpower review exercise, we actually issued personal letters to retired doctors to invite them to work in our clusters. Well, the salaries are rather low, right? That's because these doctors do not have to be on call at night. Their salaries have taken a discount because they don't have to stand by at night. Well, assuming they are consultant doctors, they are paid the rates of consultants, right? And they won't be paid as general doctors since they're retired, right? No. The responses have been rather satisfactory. So more than 200 part-time retired doctors have been serving us, equivalent to 80 full-time teachers. Can you provide such figures? Recently, we have talked about recruiting these retired doctors on a full-time basis. The government is still conducting a review, and we are also reviewing the matter. And but the situation is looking good after some initial rounds of discussions. And that means retired doctors would have two options. First, they can be renewed on a 2-year basis until they're 60, and the second option is that they can work for us on a part-time basis. I think the hospital authority can do more to recruit more retired doctors, because some of them don't want to go into private practice. And if you can provide respectable terms to these doctors, then it will be satisfactory. And these are very valuable talents. Lots of doctors are still in very good shape. They are still in their golden age, so I hope the HA can do more. And I hope you can provide longer contracts to these doctors. Right now, it's on a 1+1 basis, right? They are recruited on a provisional registration basis, right? Yes, I'm talking about overseas doctors. The offer is a 2-year contract, but since due to restrictions of the Hong Kong Medical Council, the contract is 1+1. So you have to revise those regulations. If you want to shorten the waiting times, is it that the doctors cannot be mobilized among different clusters? As I know, a lot of doctors don't want to go to West New Territories, and if something happens, there's nothing the HA can do. So can the HA actually mobilize these doctors to other clusters? Is this possible? It's not impossible, but it will only be done in case of emergencies. If we see shortages in specific specialties in some clusters, we would arrange newly recruited doctors in their preferred specialties. But as I said to Dr. K.K. Kwok, the number of specialty doctors depend on the number of wards and rooms. we would not redeploy the doctors solely based on outpatient demand. Dr. Lennon Wang. Chairman, I don't really understand the background, so perhaps the government can tell me more about it. In terms of manpower estimation, why is there such a big shortfall? And the figures have been dropping since 2007. The number of medical graduates have dropped to 250 in 2011. And the Undersecretary said the number has risen again in 2012. But as I know, only 2 universities train medical students. And the number of students is decided by the University Grants Committee. So I believe that the government would talk with UGC. So I really want to know why the number of medical graduates had been decreasing since 2007. Is it a case of miscalculation on the government's part? As you know, since SARS in 2003, Hong Kong has taken a hit in terms of economic downturn, and the demand for medical graduates wasn't so high, and as such, the number of places was reduced. And at that time, the FHB discussed the issue with the Education Bureau. But today we see that the demand is very high, and the HA is aware that it doesn't have enough doctors. And the number of medical graduates has increased since 2012, and the figure will continue to rise. Well, Chairman, that's exactly what I want to know. Because of inaccurate predictions, we are now facing manpower shortage. You said Hong Kong experienced an economic downturn in 2003. What does it have to do with the number of medical students? If the economy is bad, we need even more doctors, and we need to improve our healthcare system even more. Can you elaborate on that? I don't really see the logic in this reasoning. You are blaming SARS and economic conditions for the downturn. Is it really a decision by UGC, or was it a decision by the FHB?
Undersecretary. Chairman, I think we can provide the information at the time to members later. When the economy experience a downturn, then there is need to cut the expenditure. So at that time, we looked at the demand. We also looked at how many people would be available. So in other words, we shouldn't put the blame on the FHB. We should put the blame on the financial secretary. At that time, the economy was bad, and as a result, expenditure had to be cut. And as a result, it was decided that we couldn't have too many or so many medical students. Now, people become ill, people die when the economy is good, and these things happen when the economy is poor. So can we say that, and when the economy is poor, we should not become ill, we should not undergo operations, we should and women should not have babies? How can that be? We've just discussed a paper on revision of fees, and I understand that this is one of the measures to try to bring about improvements to public services, and another measure to achieve the same objective is to give performance pledges. So my question is this: what is considered as a reasonable waiting time for specialist outpatient service in Hong Kong. For orthopedics, the waiting time is 130 weeks. Do you think this is acceptable? The DP finds this unacceptable. And I think you have to consider shortening the waiting time to say 66 weeks or 63 weeks. And how many more doctors or nurses do you need to train up so that within a certain period of time, the waiting time can be brought down to a certain level which is considered reasonable? You can't just talk about the need to recover costs. You also have to give performance pledges. And we have cross-cluster referral arrangements for 3 specialties. Of course, it's better to have the arrangement than not to have it, but orthopedics is not included in your trial scheme. So it said that those who need orthopedics, special outpatient service, will have to wait for 132 weeks. 420 doctors for 2012. So I want to know, based on this number of graduates, how many years will we have to wait to have the waiting time brought down to more reasonable levels? I want to say that the waiting time for routine cases is long. I have to admit that. But then for priority 1, urgent, and priority 2, semi-urgent, the median waiting time will be maintained at 2 weeks and 8 weeks respectively. HA has already promised that this will be done. So HA will give priority to priority 1 and priority 2 patients to make sure that timely treatment can be given to the patients. And HA has been able to keep the median waiting time for priority 1 and priority 2 cases. Dr. Au, do you wish to supplement? I want to say that both locally and internationally, priority is given to urgent and semi-urgent cases. For routine cases, it's not the practice or the usual practice to lay down indicators when manpower resources in the wards and in the SOPCs are stretched. Then the situation is like that of a traffic jam. In other words, the waiting time will be greatly lengthened even if there aren't too many new additional cases. For orthopedics, within a matter of a few months, the waiting time for orthopedics in all clusters shot up. So in the future, we need to look at how we can increase the capacity of SOPCs in different clusters. We have to identify the bottleneck. In some clusters, there is a manpower shortage. In some clinics, there isn't enough physical space for clinic expansion. I intend to look into the next 3 to 5 years. We've only seen the first wave of problems caused by an aging population, and further waves are to come. So we have to work out short-term, medium-term, and long-term solutions. So for this referral arrangement, it's an interim measure that is carried out to try to alleviate the problem. Chairman, we are not really trying to get to the root of the problem. So we may have to discuss this problem every year. So with regard to recruitment of medical personnel, training of medical personnel, or you may do some poaching in other countries, I don't know. But do tell us what plans you have to upgrade the hardware and software in our hospitals so that within a reasonable time frame, the waiting time will be brought down to more acceptable levels. For priority 1 and priority 2 cases, your performance pledge is 2 weeks and 8 weeks respectively. But then what about routine cases? Can you try to shorten the waiting time? For orthopedics, Chairman, I hope that you can ask the administration for a supplementary paper on what's going to happen in the next 3, 5, or 10 years to address problems like shortage of doctors, shortage of nurses. How can you try to make up for the shortfall so that we know that we will see improvements after some time, and the queues will become shorter? Because in 2003 it was decided that a number of medical students should be reduced in order to save money. If this happens again, the entire community will suffer. So there's no use keep on discussing solutions which only deal with the symptoms but not the diseases. This Ms. Helena Wong. I don't know whether such information can be made available, but then this paper is about giving free choice or more choices to the patients. What you have pointed out is a much broader and bigger issue. I'll ask the Bureau when it will be ready to come back to discuss the problems raised by Ms. Helena Wong. In fact, there is the itemIII review report which is available. I don't know whether they will come back and discuss the report of us in the third quarter or fourth quarter of this year. Yes, Chairman. Ms. Helena Wong asked about our long-term plans, especially our staffing proposals. The hospital authority is constantly looking at how it can increase manpower and shorten waiting time for patients. And we in the Bureau are also working very hard. The itemIII has carried out a review, and we've got a steering committee on healthcare manpower. This steering committee looks at manpower supply in itemIII hospitals as well as private hospitals. In fact, there are 6 professions in the healthcare sector, including doctors, nurses, Chinese medicine practitioners, and for these professions, there's a shortage of manpower supply. And we are looking at the manpower supply in these professions in conjunction with the healthcare financing proposals. We hope that people who are now using HA services and who can afford private sector services will turn to the private sector while being assured that there is the safety net provided by the public sector. So, Chairman, we're just trying to report to members the rolling out of this referral arrangement. This is not the only measure that we are relying on to solve all the problems. Mr. Yu Si-wing. So, of course, you have to give priority to urgent and semi-urgent cases, and as a result, routine cases need to wait for a longer period of time. Yes, you're giving them some more choice, but then most of those of chronic illnesses are elderly patients. They don't know how to check the waiting time in different clusters and in different specialties on a website. For those elderly patients who are smart, who are educated, maybe they know how to do it. But then for the many of these patients are in the vulnerable groups. How can you enhance the arrangements? Now, say if a nurse, after assessment, decides that this case is a routine case, then can the nurse look at the waiting time in the cluster for that specialty and then tell the patient that the waiting time in this hospital and this cluster is rather long, and so you may want to consider receiving treatment at another hospital in another cluster. So can you ask the nurse to assist? Because not all patients with chronic illnesses know how to check the waiting time on the HA website. Or the nurse may advise the patient and explain to the patient that instead of waiting for 3 years in this cluster, the patient should go to another cluster where the waiting time is only 1.5 years. So can you give such guidelines or instructions to the nurses so that they can provide some assistance to the patients?
As I understand, as Dr. Au already said, we have done work on both fronts. On one hand, for new cases, patients can go to clusters with shorter waiting times. And if a patient visits his own cluster, the medical professionals would explain to the patients and advise them on clusters with shorter waiting times. So perhaps Dr. Au can tell us the details of this mechanism. According to the existing practice, the nurses would remind the students upon registration. And that's because we felt that merely posting the waiting times online is inadequate. We have decided to post tables of waiting times in the hospitals so that the patients can take reference. For routine cases, most patients would not want to be referred to other clusters, and because they don't want to visit somewhere they've not been to before. We have tested this program for about 2 months, and 2 months later, if we see room for expanding this program, we would consider regularizing this arrangement. We would suggest our frontline staff to remind the patients, but this would not be a compulsory arrangement because this must be addressed on a case-by-case basis, and not all cases are suitable for referrals. Since we are talking about a referral arrangement, we should seek to improve it or refine it. Can you share with us the number of patients referred to other clusters after they learn about this program online? Do you have such figures? If you have such figures, we can be more clear about our objective. You said there will be a 2-month evaluation exercise, and perhaps we can provide some incentives or encouragement to doctors or hospitals that have done well under the referral arrangement. And as such, we can give each hospital a target to work towards. Right now, we cannot see how well different hospitals have done. You talked about 1.5% or 2%. Do you have such figures? We will consider your suggestion. And it might be hard for us to categorize these referrals according to their nature, because it has something to do with the details of or personal information of the patients. But we'll certainly encourage clusters to learn from each other and adopt best practice. Chairman, I understand that our medical professionals have a lot of work to do, so our initiatives should be incentive-based, and we should not increase their workloads substantially. We can just give them a checklist or something. We should not criticize hospitals for not doing enough, and this is unnecessary. Of course, we want to continue to refine this arrangement and extend it to other measures in the future. So that's our ultimate goal. I believe the administration has heard your view. Any other questions? If not, we have had ample discussions on this item. I'd like to thank Dr. Au. And sixth item, any other business? We have no other business so far. And we started 15 minutes late, but surprisingly, we managed to finish 15 minutes ahead of time. Next time, we'll come back to discuss the 3 remaining items.